So let's go ahead and talk about treatment options for the complex patient. What are the options? These are my disclosures. The US Department of Health and Human Services treatment guidelines for patients with HIV infection specifically deal with the issue of managing antiretroviral therapy in patients with virologic failure. Among the first steps to take is to evaluate the patient's adherence, whether there may be any drug-drug interactions that are interfering with absorption or metabolism of the drugs that the patient has been prescribed, issues around tolerability, and of course, whether there's any evidence of prior resistance to the current regimen. Then for the patient who is viremic and failing on therapy, performing drug resistance testing is really a key component of selecting any subsequent regimen. The goal of treatment is to reestablish virologic suppression. A new regimen should include at least 2 and preferably 3 fully active agents. Adding a single antiretroviral agent to a virologically failing regimen is not recommended. For some highly treatment experienced patients with extensive drug resistance, maximum virologic suppression may no longer be possible because of the lack of adequately potent and active drugs. In such cases, treatment regimens should be designed to minimize toxicity, preserve CD4 cell count, and delay clinical progression. This slide shows the frequency of high-level drug resistance in the United States and how patterns have been changing over the 10 or 11-year period between 2006 and 2017. These are data from specimens submitted for resistance testing to a large reference laboratory reported by Ron Kagan. If you just focus on the right-hand panel, what you can see is although single-class resistance had increased, and that was really a resistance to the non-nucleoside RT inhibitors, so did the number of samples submitted without any evidence of resistance. And most importantly, triple-class resistance was on the decline. So the good news is that for most patients today, high-level triple-class drug resistance is really a rare event. However, we do still have such patients and they do need new regimens. Now, if we look back in time at when we were first best able to treat these patients, we know that the TRIO study that combined a novel, at the time novel boosted protease inhibitor, darunavir, with a then novel non-nucleoside RT inhibitor, etravirine, which had activity against some resistant viruses, and raltegravir, then a new first-in-class integrase inhibitor, that the combination of these 3 new drugs was able to dramatically turn things around for patients with resistance to the older generation of protease inhibitors and multi-drug resistance, with about 90% of them being able to achieve virologic suppression. We also know from the ACTG options study that in the setting of high-level drug resistance, so long as you can provide at least 2 active drugs, if there are no active nucleoside RT inhibitors, then omitting the NRTIs from the regimen really is of no consequence, and it may not be necessary to include nukes that may add complications or toxicity to the regimen with very little virologic benefit. Then the Viking study looked at the use of twice-daily dolutegravir in patients who had already developed resistance to raltegravir. What you can see in this slide is that the fold change in dolutegravir resistance was related to the number and type of raltegravir resistance mutations, with viruses that carried a mutation at position 148 and 2 other mutations having the highest fold resistance. What this study also showed was that if you gave the twice-a-day dose, then you were highly likely to be able to achieve virologic suppression, more so than in the once-daily dose, although the participants who received the once-daily dose on average had higher levels of resistance than in the twice-daily component of the study, so it's not a completely fair comparison. This slide shows those efficacy data, and you can see that for the twice-daily regimen, 75% of the patients achieved full virologic suppression, and more than 80% got to less than 400 copies compared to just 40 and 50% in the once daily arm. Well, let's talk about some more recently introduced therapies. And to do that, we first have to go back and take a look at how the FDA in the United States is now recommending that salvage therapy studies be done. Because recall that what we want to avoid is the use of a single new drug for any significant duration of time in order to prevent the emergence of resistance to that new remaining active agent, as well as to protect any remaining drugs in the background regimen. So the scheme here is to randomize patients to a brief period during which they either add placebo or add the new investigational agent to the current failing regimen for a relatively brief period of time, no longer than 2 weeks, at which point the change in virus load can be assessed, really giving a picture of the activity of the new drug. Then the background regimen is optimized and participants continue to be followed in order to assess the long-term durability of the regimen as well as long-term safety. This design was first applied in a phase 3 trial of ibalizumab, a monoclonal antibody that is derived from a mouse antibody, 5A8, which has been humanized. It belongs to the IgG subtype 4. It recognizes a unique epitope in domain 2 of CD4 on the external part of the molecule and inhibits post-binding entry of HIV. It doesn't block attachment of the virus to CD4, but it prevents subsequent interactions with CCR5 and virus entry. This slide shows a three-dimensional structure of the heavy and light chains of ibalizumab binding to domain 2 of CD4. The way that this antibody binds does not interfere with the normal function of CD4 in antigen presentation, and nor does it prevent binding of GP120 to CD4. These data taken from the phase 1 study of ibalizumab that was done 16 years ago show dose-response relationship with at the highest doses, nearly a 1.5 log decrease in viremia achieved at 14 days after a single dose. So here we see the phase 3 design of the ibalizumab registrational study. In this study, participants were screened, then they were observed for a control period of 7 days in order to determine any fluctuations that may be occurring in the level of viremia. They all then received a loading dose of ibalizumab and were observed for a 7-day period of functional monotherapy, after which they could optimize their regimen, continuing to receive an 800 milligram dose of ibalizumab intravenously every other week for the next 23 weeks, and then were followed for safety. This slide shows the virologic response data. You can see that during the control period, only a single individual had a half-log reduction in viremia compared to 33 of the 40 participants, or 83% during the functional monotherapy period, and this was highly statistically significant. This was the primary endpoint for the trial. In addition, 60% of the participants during the monotherapy period achieved a 1 log or greater reduction, with the mean change in virus load from baseline being 1.1 logs, obviously much greater than what was observed during the control period. If we look at changes in viremia based on baseline CD4 count, there were many more participants who achieved reductions in virus load who had, if they entered with more than 50 cells per microliter at baseline compared to those with more advanced disease. We can also see that the log reduction in viremia was greatest in those with baseline CD4 counts above 50. And if we look at restoration in CD4 counts, once again, those who entered with less advanced disease had about a 75 cell increase compared to those who had the most advanced disease, and they had only about a 15 or 20 cell increase. Looking at the safety of ipilimumab, there was really no control group here, so it's very hard to assess completely, but you can see that there were a series of adverse events that are typical of what we see in patients with advanced HIV disease. No particular events really stand out, and as we've come to expect with monoclonal antibody therapy, there are really generally no significant toxicities unless they are related to the action of the antibody. Now, one can see resistance to ipilimumab. These data are taken from an earlier phase 2 trial that was conducted many years ago. And what you can see is this a decrease in the maximum percent inhibition, much as we used to describe for resistance emerging to the CCR5 antagonists. And these viruses that have developed resistance have particular changes in the V5 loop, as illustrated here and mapped to the three-dimensional structure here. These involve glycan sites at V5 and prevent the binding of the interaction of the envelope with CD4. They're not really affecting so much binding of ipilimumab to its target, which of course is a host cell protein. Well, let's turn to the other new drug, another entry inhibitor. This one is called phostemsphere, and it is actually a prodrug of the active agent temsivir. This is a first-in-class attachment inhibitor that does bind directly to GP120, and by doing so prevents the interaction of GP120 with CD4. This drug is active against viruses regardless of tropism, so it is effective against R5, X4, and dual tropic viruses, and it's synergistic or additive when combined with other anti-HIV drugs. Here you can see this phosphate group is removed to generate the active drug temsivir. Like the phase 3 study for ipilimumab, the Bright trial, which was the phase 3 study for phostemsphere, used an approach that was guided by the FDA's recommendations for salvage therapy trials in the modern era. In this case, 2 studies were conducted in parallel. Patients who had at least 1 or 2 fully active antiretroviral drugs as remaining options entered into a randomized study and they were randomized 3-to-1 to either begin receiving phostemsphere 600 milligrams twice daily or placebo, both groups continuing their failing regimen. And they did so for an 8-day period, after which all participants were able to receive open label phostemsphere and optimize their background regimen. So the primary endpoint was the change in virus load at day 8. In addition, for patients who had no remaining active drugs, they were allowed into an open label study, essentially a compassionate use study that was an observational study to determine what effect phostemsphere might have, but without any comparison group. This slide shows the results in terms of virologic suppression for both the randomized and non-randomized groups. You can see that in the randomized cohort, recall that these individuals had at least 1 remaining active drug, that 84% were able to achieve a virus load less than 200 copies and 62% less than 40 copies at week 48. Whereas in the non-randomized cohort, about 50% were able to achieve less than 40 copies, and just under 55% achieved less than 54% achieved less than 200 copies. If we look at the primary endpoint, which was the change in virus load from baseline to week 8, you can see that in the phostemsphere group, there was about a 0.8 log reduction compared to a little more than a 0.15 log reduction in the placebo group. And this difference was statistically significant, demonstrating the activity of phostemsphere when added to a failing antiretroviral regimen. About 65% of the participants achieved a half log reduction and 46% a 1 log reduction during this 8-day period. There were also significant increases in CD4 count. Here, the randomized cohort had nearly a 140 cell increase by the end of 48 weeks, and the non-randomized cohort had about a 64 cell increase. If we look at the comparison of adverse events, there are really no significant differences between the randomized and non-randomized cohorts, again, because all participants were receiving phostemsivir after day 8. There isn't much of a basis for comparing the incidence of adverse events with a true control group. We can see that, once again, these are primarily the types of adverse events that we see in people with advanced HIV disease. So in conclusion, the goal of treatment for patients with complex antiretroviral treatment histories is full virologic suppression. New drugs with novel mechanisms of action increase options for constructing treatment regimens containing 2 or more active drugs. When full virologic suppression cannot be achieved, ART regimens should be designed to minimize toxicity, preserve CD4 cell counts, and delay clinical progression.